Classmates, and welcome to our symposium on COVID infections. It's been a long time. I'm Alan Cross, joining from Chevy Chase, Maryland, and I'll be the moderator of this session. Before introducing the panel, I would like to give you a brief overview of what we have planned. Each of our Classmate physician panelists will give a 5-minute presentation based on their unique perspective of the pandemic. We wish to encourage audience participation. So these presentations will be followed by pop questions for the audience that will ask about your experience with COVID and remarks by our classmate, Steve Bergman, who came down with COVID. This will be followed by a panel discussion based on questions you, the audience, pose to the panel, and these will alternate with a discussion of difficult issues raised during the pandemic. At any time, you may ask a question in the chat room and send a message directly to our panelists. And we ask that you, if possible, indicate who you're addressing the questions to. You may also wish to make a comment. However, there'll be a few ground rules so that everyone may have the opportunity. Comments must be limited to 3 minutes or less. No speeches, no political statements. Remember, I have the power of the mute button. You're also able to indicate if you want to make a comment, but we ask that if you indicate that in the chat box that you at least comment about the topic that you're about to comment on. So with these comments in mind, I plan to ask the panel to introduce themselves and indicate their current status. So we'll start with Dick Olans. Dick?
Thank you, Alan. I'm Dick Olans. I've been a community-based infectious disease physician at several community hospitals north of Boston for my entire career, with a few travels to other places for interesting infectious disease experiences beyond the realm of this talk. But mine is the duality of the community-based physician's perspective, because during the COVID pandemic, I had dual responsibilities. One as an infectious disease doc, caring for individual patients and their families, but secondly, as a public health member of Melrose Wakefield Hospital's incident command team, with the responsibilities of keeping the hospital operational and functioning, and also protecting the hospital staff and employees, as well as the patients, to accomplish that goal. The perspectives of these dual responsibilities were often aligned, but sometimes had divergent priorities. And in that regard, my community hospital represented a microcosm of what the country's issues faced throughout the pandemic. So I hope to give you a sense of that in 3 brief example anecdotes. Let's start February 23rd, 2020. One of our ICU physicians, a woman of Chinese descent, a society more accustomed to its citizens wearing masks in public, informed me that she was ordering a dozen Tyvek bodysuits and 2 boxes of N95 masks from Amazon that she wanted to use for herself and the ICU nurses, that she was worried what might be coming shortly to the United States. As an infectious disease physician, I couldn't fault her concern, but as the hospital epidemiologist, I couldn't support the limited distribution of personal protective equipment solely for the intensive care unit, while neglecting the emergency room, the medical COVID units, as well as housekeeping, environmental services, and laboratory and radiology, who are servicing the ICU as well. So we did not use the Tyvek suits. They were in limited supply and would have only covered less than a week at most anyway, and continued as a hospital to procure PPE, personal protective equipment, for all personnel as quickly as we could. Second example, March 11th to 21st, 2020. 3 of our most experienced nurses from our initial COVID isolation unit developed mild symptoms and were tested positive for COVID. They all stated that they'd been religiously adhering to hospital isolation guidelines, but they and we had overlooked the small nurses' break room with a single table and four collapsible chairs where they took their hurried 10-minute meal breaks. All three of them subsequently had to be quarantined at home, but thankfully there were no secondary cases either in the hospital or in their households. The incident command team subsequently commandeered other public socially distant spaces for food consumption. Other Massachusetts and US hospitals had also overlooked how difficult it really is to eat a meal through a mask. They had similar consequences, some of them up to outbreaks of 30 personnel. Then we go to March and April of 2020. Before the US supply of N95 masks improved, the hospital was flooded with donated cloth masks, diligently prepared by, I like to think of all Betsy Rosses sitting at home with their sewing machines. But the infectious disease physician scientist in me was publicly polite, but privately skeptical, feeling that the cloth masks were inadequate and inferior to the conventional hospital surgical masks. Only months later would studies show that the double masking, the use of cloth masks over the surgical mask, were actually superior viral barriers than the surgical mask alone. Time heals all wounds, or in this case, wounds all heals. Then May 11th, 2020, what I call the first responder caravan. A network of first responders, police, fire, and EMT organized a rally of fire engines, ambulances, police cars, and they all caravanned down Main Street, circled the hospital, lights flashing and sirens blaring, saluting us for 10 minutes in support of all of the hospital employees. And thanks for their service. One budding Vincent van Gogh had even chalked in multicolors on the side of the hospital, Melrose strong, and hope is stronger than fear. So I still choke up remembering that, watching them go by. Now let's move ahead. May 2021. So now hundreds of boxes of N95 masks and thousands of doses of vaccine later, we're at a time when the most recent Centers for Disease Control guidelines are relaxing for masking out of doors and in small vaccinated groups. So what do I think about this with my schizophrenic dual personality here? Public health epidemiologist in me says, maybe we have reached that tipping point when incentives for normalizing society with vaccine-enabled travel, sports events, safely gathering in large groups will stimulate more vaccine-hesitant individuals to become immunized, more than our previous endless lecturing to the unwilling that prevention, quite simply, is better and safer than the disease. But the skeptical septic in me, the individual ID doc, might caution a more tempered approach. There have been epidemics before, and there will be more epidemics in the future to come. So don't throw away all of your masks just yet. And in the words of Hill Street Blues, careful out there.
Okay, thank you, Dick. Next, we have a view from the emergency room with Toby Nagurney. Toby?
Thank you, Alan. First, I want to acknowledge the leadership of Alan and running our panel and thank my co-panelists, Beverly, Dick, Paul, and Michael for working together, and thank Randy and Kim for their technical support, and thank our classmates for attending this. As Alan mentioned, my perspective is that as an emergency room physician, I work in one of the downtown academic medical centers in Boston, and we were kind of targeted to receive most of the COVID patients in our 6 hospital system. So we have seen, and I have seen many, many COVID patients over the last 1+ years, and that's my perspective, pure clinical care. So I'll begin naturally with the patient point of view and talk a little bit about what I think this COVID-19 meant to patients. The first point I'd make is that when patients came to the ED or ER, they didn't know they had COVID. All they knew was that they had a cough, or they were short of breath, or had one of 6 other symptoms, and they were frightened. The worst fear was that they had COVID. And the reason they were afraid they had COVID is because they had figured out from the press that based on initial data, the mortality rate for COVID-19 was 200 to 300 times more than seasonal flu. Seasonal flu is 0.1, COVID was originally reported to be 20 or 30% mortality. So it was really scary. They also had kind of figured out, one of the shocking things was that people of all ages got COVID. And in ER, most people you see who are sick are our age, frankly. They have a lot of comorbidities. Here we saw patients 40 years old in the prime of life, just knocked over with COVID. And children got it too, not as many, but one of the patients I cared for was a 9-year-old whose heart stopped 6 times and we shocked 6 times to restart the heart. So it was very dramatic and a disease that affected all ages. The other thing that patients recognize is they were never out of the woods. Classically, if you contracted COVID, you'd get sick within about a week to 10 days after the infection. But we have patients who weeks after getting COVID and getting better, just had a second spike and got dramatically worse. A 35-year-old woman who was getting dramatically better from her shortness of breath, and then her heart stopped pumping and she had to be put on a bypass machine. So you were never safe with COVID. It affected every organ system. The lungs got the press and the ventilators and all that, but it affected the heart, kidneys, patients were put on dialysis, it affected the brain. So it was really pleomorphic. And the last and most impressive thing, I think, from a patient point of view, was that it was a lonely death. When patients are very sick or dying, they come to the ER, they're surrounded typically by family, they hold hands, they say prayers. With COVID, you couldn't. We could not allow family members to accompany patients. So patients were there alone and they knew they were sick. And I think the most vivid memory I have of COVID was a patient about to be put to sleep, be put on a ventilator, given a breathing tube, knowing they may never wake up, and asking for a cell phone to call their family with tears in their eyes. And the tears were among our entire staff as well. It was really difficult. So segueing into providers, that's pretty much it. It was an overwhelming experience for most providers. You saw the clips from ERs in New York and LA. They were like war zones. It was overwhelming, not only because of the volume, but because we really couldn't help patients as much as we wanted to. Even now, the armamentarium for COVID is not so great. Remdesivir and steroids work a little, other things have not worked. There's really very little we can do, and to see your patients getting sicker and dying in front of you was really quite dramatic and difficult. The other things we noticed were the personal risk. Even if we were vaccinated, most of us were, our families were not. My wife didn't get vaccinated until a month ago. So you had all that, and then you had how to deal with the personal risk. And the main thing for providers, I think, was that it was really isolating. So I was considered cavalier because I just wore 4 layers of clothing at work, changed into hospital clothes and out of hospital clothes, took showers after every shift, but I at least lived at home. I have colleagues who moved to a hotel for 9 months and didn't see their family, didn't see their kids, didn't see their elderly parents. It was particularly hard on moms with young kids and providers with elderly patients. So that was really, I think, the most impressive thing for providers. And there was collateral damage. One was that there were a handful of suicides among physicians that were well reported. Less dramatic was the fact that what the press didn't pick up was that hospitals and ERs were downsizing. So the first thing that hospital administrators do when you have decreased volume is you decrease the number of shifts in providers. So ironically and paradoxically, the first line providers that Dick mentioned were having horns blown for them and being lauded by the press are being downsized or fired or losing their clinical time or their shifts. And then lastly, if they spoke out against certain institutions, not all, I work at a terrific hospital, but if they spoke against certain institutions, they were summarily fired. So that was, I think, the collateral. And I would say my summary is that I've had the good fortune to work in ERs for 40 years. I've seen Ebola cases. I was in our ED during the Boston Marathon bombing. So I've kind of seen most of it. And there's been nothing even remotely comparable to COVID. And so for silver linings, I think that I think it demonstrated what we all knew, the enormous inequity in our healthcare system among the haves and have-nots. I think just italicized that, COVID did. And I think it taught many of us, providers and patients and all of us, that something as simple as being with your family on a warm spring day in a park is really kind of special. I think the price is 600,000 American deaths, millions of deaths worldwide. But I'd like to close by, if those of you who are classmates remember Hum to Your Humanities 2, taught by professors Finley and Alfred, and it was epic and drama. And I refer to the drama part and quote Samuel Beckett, the playwright, who said, "Ever tried, ever failed, no matter, try again, fail better." Thank you.
Thank you, Toby. Next, we'll hear from Beverly Winikoff, who has a perspective from women's health. Go ahead, Beverly.
Public health physician. I'm currently the president of the Genuity Health Project, which works on reproductive health and maternal and child health. And so my vision is actually quite different from a practicing physician and also from an infectious disease physician. It's more of a 1,000-foot view of what it's done to areas in maternal health and reproductive health. So the novel coronavirus has created huge challenges for the entire medical system, so-called, and laid bare a lot of deficiencies in our healthcare system. Indeed, the shape of all of the healthcare in the US is produced not by any one thing, but an interaction of history, politics, law, culture, science, and also medicine. In the next few minutes, I am going to reflect on what has happened during COVID in another seemingly unrelated domain of health, and that's reproductive health, especially abortion, and specifically the use of pills for abortion. So to begin the story of abortion pills, I'll remind us all that the FDA approved these pills for abortion in the year 2000. Based on continuing research and improvements in the method, we're now able to provide this treatment for early abortions successfully 98 to 99% of the time. In part because of these pills, the last years have seen a rather revolutionary change in patterns of abortion services. And some of the most important changes are that most abortions are now actually very early. More than 90% are in the first trimester. About 88% are within the first 12 weeks of pregnancy. Also, abortions are becoming less frequent. They're down 20% or more from 2011, with a population that is actually larger. So a lot of this has to do with the fact that the use of pills is increasing rapidly. When they were first given approval by the FDA, they constituted about 5% of abortions that year. And the latest figures, which are not the actual latest figures, but the latest we have, is that 60% of all abortions under 10 weeks, which are a huge majority of abortions, are done with pills now. So abortion is not what you think it was. But at the same time, 58% of all US women now live in states that are hostile to abortion. So there's a countervailing political issue. I want to note specifically two threads that have been especially important in the pandemic context. First, the FDA and the mailing of abortion drugs, and second, the use of telemedicine for abortion. So the first thing has to do with getting drugs without going to an abortion facility. And that history is interesting. The original approval of mifepristone, the abortion pill, came with numerous caveats and restrictions called the REMS, which is the risk evaluation and mitigation strategy, because the drug was said to be dangerous, which it was politically for the FDA. That set of rules contained prohibitions on pharmacy access, that you can't go to a pharmacy and give a prescription for an abortion pill, and no mailing of the drug. It had to be handed to a person in a clinic. During COVID, a federal district court judge in Maryland ruled that the pandemic had made it too difficult for people to safely get to clinics, and therefore that particular aspect of the regulation should be stayed. It wouldn't be in effect. But the Trump administration immediately asked the Supreme Court for an injunction to lift that stay, and the court granted it. So we had this little whiplash about at some point we could mail the drug, and at some point it got taken away again. But then when the Biden administration came in, they cited new data to the Supreme Court and got the stay reinstated for the duration of COVID. And another interesting thing is that the FDA was charged to do a full review of the entire set of regulations that govern the pill, which is still ongoing, and we don't actually know what's going to happen, but we think that this may be a chance to stop the nonsense of not being able to pick it up in a pharmacy, but we will see. The other big tendency that has been spurred by COVID is the adoption of telemedicine for abortion services. As you all know, telemedicine has been rising generally as a way to have health services, but it hadn't been used very frequently for abortion. Our organization started a telemedicine service for abortion as a study with the approval of the FDA in 2016, and that project is now operating in 7 states and the District of Columbia. What it entails are Zoom calls between women and providers. Any tests needed can be done elsewhere at any lab or other health facility. And then pills are mailed. And as this was a registered with trial with the FDA, the restrictions didn't apply to not mailing them. So women would go get on the phone, have a video conference with a provider, and then if there were any tests that were needed, send those results in, and the pills would be mailed. Thousands of such abortions have now been documented and published in respected scientific publications, both ours and also a large number from UK. And all of these evaluations show no important differences in outcomes using telemedicine and mail drugs to the usual way of getting a medical abortion. And with incredibly high satisfaction among users, most of whom said that they would, something like 98% said that if they had another abortion, they would do it this way. And as a group of providers, it's very impressive to hear the desperation of the callers and the relief when they realize they can have a safe service without having to go out during a pandemic. Like one mother who had no babysitter for her immunocompromised child, but feared bringing him to a public space during COVID if she had to travel to an abortion clinic. For us, it's been extremely gratifying to be able to offer this service, and I'm happy to answer any questions in the question period. Thank you.
Thank you, Beverly. Now we'll hear from Michael Gottesman, who will give us a perspective from inside the NIH. Michael?
Thank you, Alan, and thanks to all the members of the panel and the audience. I'm the Deputy Director for Intramural Research at the NIH. And it's an interesting story about how that came about, because the physicians on the panel remember that when we graduated from medical school, every physician in the country was drafted because of the war in Vietnam. Some went to Vietnam, some stayed here. And the ones who stayed here, if they were lucky, like I was, could get into the public health service. And the public health service was one of the arms of the Department of Health and Human Services that allowed people to work in research activities, or the Indian Health Service, or the CDC, and so on. And so I came to the NIH, and I've been there ever since medical school, basically doing research, cancer research. And for the last 30 years, I've been responsible for overseeing what's called the NIH Intramural Research Program. The NIH has a big budget. It's one of the largest discretionary budgets, currently around $45 billion in the Department of Health and Human Services. And it has 2 components. One is the extramural program, which gives grants and contracts to academic centers, industrial centers, academic centers in combination with industrial centers, pharma, and so on. And the other part is the intramural program, which are the federal laboratories. Basically, most of our work is done in Bethesda, but we have labs throughout the country. And so the response to COVID, literally within days after we became aware of the extent of the problem, had both an intramural and an extramural component. And I'll tell you a little bit about the intramural component, and then give you some idea of the scope of what happened extramural. So NIH had 2 major goals. The first was to understand the pathophysiology of this new disease. find ways to prevent it, in other words, with vaccines or monoclonal antibody treatments, improve diagnosis, make testing more rapid and more available, and of course, if possible, to develop treatments that would be effective for treating COVID-19. But in addition, we played an additional role, which was to be the, we hope, trusted source of information that could be conveyed to the public and to public health experts to inform decision-making. And as you know, that part of it had sort of a mixed reception by the administration and also by the public. All the work has been done in collaboration with the academic sector and with biotech and pharma. So let me tell you a little bit about what's gone on at the NIH, because it's pretty amazing. And one of the important contributions, obviously, was the contribution to the development of the vaccine. And the story here is that two of our scientists, Barney Graham, who's been at the NIH a long time, and one of his senior colleagues, Kazmikia Corbett, who's a senior fellow, began to work on a vaccine based on studies they had been doing for years on a vaccine against SARS and MERS. These are other coronavirus diseases. And they discovered they could make mutations in the spike protein that would stabilize that protein, make it a really good antigen, and that they could do a sort of plug and play that an existing vector. They could stick the spike protein into that vector and get high levels of expression. And they collaborated with a company called Moderna, and the Moderna vaccine is a result of that collaboration. The Pfizer vaccine is a very similar vaccine, also based on some of that genetic engineering that went into the vaccine. In case you wonder why the vaccine is a better antigen than having the disease itself, you're less likely to get infected if you've been vaccinated, fully vaccinated, than if you've had natural infection. It's because the scientists involved really engineered this. When we first saw the data coming out of the studies indicating an incredible response rate, 95% protection against disease, hundreds of millions of doses now with very few serious side effects. It was really very much like NASA must have felt when they put a man on the moon. It was just an amazing feeling to be involved in what is really, hopefully, going to be a solution to the problem that we're facing now. Now, there were other studies going on at the NIH. You heard about remdesivir, one of the first approved drugs that was studied first at the NIH. And another interesting story has to do with one of our biophysicists who was interested in how the disease is spread. And he developed a way to visualize the droplets that come out of your mouth when you sneeze, when you cough, and when you speak. And it turns out that speaking produces just the right size droplets to get into the lungs of people who are downstream from speakers. And he also showed that almost any face covering, certainly cloth masks and paper masks that people were using, made a dramatic difference in the number of these particles. So that was part of the reason that the CDC changed its tune early on and agreed that masking was really an important aspect of preventing the spread of this disease. Now, on the extramural side, there have been enormous investments. One of them is called RADx, for Rapid Acceleration of Diagnostics, which was aimed at developing much better ways of detecting the disease quicker, point of care tests, home testing kits, which are now available. You can go to CVS and get a home testing kit. All of that technology came out of what they called a Shark Tank. This was a competition among biotech to come up in a matter of months with the best techniques, new techniques for measuring the existence of this virus. And they were able to do that. There was also a considerable focus on underserved populations, people who either didn't have ability to get some of the tests or were reluctant to be tested, reluctant to get vaccine. And NIH has made a major effort to understand the social science of that kind of behavior. Another very important approach, and I think Alan may say more about this, is something called ACTIVE, which is accelerating COVID-19 therapeutic interventions and vaccines. And the point of that was to develop trustworthy clinical trials. If somebody says hydroxychloroquine is a great way to treat the disease, well, is that really true? And NIH has been involved in testing many of the therapeutics that have been suggested. And I have to say, a lot of the drugs that have been suggested to be repurposed have turned out not to be very useful in treating this disease. And then finally, I just like to say that you probably can't turn on your TV without seeing Tony Fauci and Francis Collins. They are NIH representatives, and they've been making an effort really from the beginning, working 20 hours a day to try to communicate the facts about this disease and help people figure out how to deal with it and inform both the public and the government about the best way forward. So I'm happy, obviously, to answer questions as well during the question period. Thank you.
Thank you, Michael. And next is Paul Lankin, who has a background in intensive care unit as well as bioethics. Paul, take it away.
Thank you, Alan, for inviting me. Interesting to hear from Michael and the NIH perspective. I finished college and went to med school and then did internship and then was drafted and actually did go to Vietnam. And then I came back and did a pulmonary critical care fellowship at the University of Pennsylvania. And that's where I've been for the last 42 or so years. As a pulmonary intensive care doctor, I spent a lot of time in the medical ICU, dealing with patients who were severely ill and dying, living through a number of different epidemics, including Legionnaires and AIDS. I became interested in bioethics. I'm an emeritus professor of both medicine and medical ethics and health policy. Back in the 1970s, when Karen Ann Quinlan's case was decided by the New Jersey Supreme Court and withdrawal of life support. I'm retired now from clinical practice. I stopped doing the MICU rounds about 2-3 years ago, and I finished my my last rotation in a long-term acute care unit that we have at Penn on Friday, the 13th of March, 2020. And my supervisor told me to go home and stay home since I was the oldest intensivist there in the division. I can tell you that I felt some pangs of guilt as I saw what was happening in New York City in the desperate situation in the ERs and the ICUs and the hallways. But I felt comfortable staying home and being a sort of observer of events. This pandemic has been a catastrophic challenge for medicine, nursing, and bioethics. And I have a slide, if Kim, you could put it up. It's just some thoughts that came to my mind in response to the invitation to share with you some of my comments. And these are issues for healthcare providers that arose during the pandemic, thinking about ethics in a very broad sense of professionalism, humanism, and policy. And the mass casualty is something that we don't face too often in civilian life. It really was met with a number of different ways of handling it. My hospital basically shut down everything except the emergency room and the ICUs. And we tried to accommodate all of the COVID patients. The state of Pennsylvania developed what were called the crisis standards of care, which were an extraordinary type of a guideline to help clinicians ration life-saving care. And I don't believe that we were able to, we needed to do crisis standards of care at my hospital, but I'd be interested in the audience and if there's any clinicians out there, what they experienced. Clearly, it's going on across the world. If you just turn on your TV and learn about what's happening in India. There's some talk about immunity from liability because you didn't meet standards of care. We had a number of research ethics questions about who gets vaccinated in the trials, and then whether or not you would be willing to undergo challenges with COVID before there's a cure for COVID. Professionalism really took a hit, I think. There was a major movement to family-centered care and shared decision-making. We could say goodbye to family-centered care because no family members were allowed in the hospital or the ICU. Nurses would try to get their image on an iPad. Some issues of reactions to clinicians working in hospitals, and then going out on the street and seeing people without wearing masks during surges, and feeling like there really is something wrong with this picture. The humanism, I think most clinicians who didn't work in medical ICUs, where we had a 20% mortality before the pandemic, really were overcome and overwhelmed by the amount of death. I think there was a New York City health system reported 90% of patients on ventilators and ICUs died. The health policy issues relating to distribution is an important one. We have enough vaccine in America for all the Americans, but clearly the world still needs vaccinations. And I think anyone who is a practicing clinician, and I take my hats off to Dick and Toby on the panel, bravo for supporting the endeavor and with your self-care and emphasizing wellness. I think it's not going to go away. There will be post-traumatic stress for quite a while by the clinicians. I just read yesterday that 3,600 nurses died from COVID during the pandemic, and I certainly grieve for that loss of humanity and nurses. Thank you very much, Alan.
Thank you, Paul. And last but not least is myself. And I, like the rest of my physician classmates, was drafted after the graduation from medical school. I took a different turn. I ended up at the Walter Reed Army Institute of Research, where I stayed for 20 years before I moved to the Center for Vaccine Development at the University of Maryland, where I now am. This COVID-19 pandemic is unique in many ways, and I will summarize the unprecedented rollout of so many different vaccines in a short period of time, and then discuss what we know and don't know from clinical trials. For on this latter point, I'm often asked, is vaccine X better than vaccine Y? With the identification of the spike glycoprotein by which the virus attaches to the human cell as a vaccine target, its genetic sequence was identified and published on January 10th, 2020, within 40 days of the first identified case. This served as a roadmap for rapid vaccine development using various novel technologies to deliver the vaccine protein. There are over 80 different COVID vaccines currently in development worldwide, and all vaccines currently evaluated in the United States are based on the spike protein and vary in their attributes. Moderna and Pfizer, as Michael mentioned, package messenger RNA for delivery into cells so it can direct the synthesis of the spike protein antigen. The mRNA vaccines were manufactured and delivered for clinical testing within 45 days of the publication of the genetic sequence. Contrary to popular knowledge, and as indicated by Michael, this technology was based on work done over 10 years ago. And now with research at the NIH Vaccine Research Center and support of the federal government, this technology is employed against other viral infections like Ebola and Zika in a plug and play type of platform technology. The AstraZeneca, Oxford, and Johnson & Johnson vaccines deliver the spike protein in different non-replicating adenovirus vectors that infect the host cell. Another company, Novavax, packages the recombinant spike protein in a lipid nanoparticle that's given with an adjuvant to stimulate the immune system. Each of these vaccines require novel reagents and packaging technologies, sophisticated manufacturing procedures, and trained personnel. As we now appreciate, this also demands a public health infrastructure to deliver the vaccines. Those vaccines that require storage and deep freeze must have stoppers and glass vials that withstand very cold temperature, and only one company makes such vials. Each of the vaccines mentioned have undergone extensive phase 3 clinical trials for efficacy and safety. And as of this day, 3 have received emergency use authorization in the United States. While these vaccines, as well as the AstraZeneca and Novavax vaccines, vary in their ability to prevent infection and/or mild symptoms, each is 100% effective against hospitalization and death. The vaccines were developed with impressive speed, but for me, as a clinical investigator, I was equally impressed that a phase 3 trial could have been done so quickly. Oftentimes it takes years. And this is a tribute to how many COVID infections were actually circulating in the population. Once the vaccines were distributed for use in this country, the question was often asked, which vaccine is better? Well, unless the vaccines were compared in the same head-to-head clinical trial, however, it's not possible to answer the question since the clinical trials differed significantly in design. Consequently, the simple point efficacy comparison, X% versus Y% for another, without consideration of the design is not useful. So the following factors must be taken into account in comparing the vaccines. First, the characteristics of the study population. What is the prevalence of the older age or those with chronic conditions or frailty, which would lead to lower immunogenicity and efficacy? Minority populations may have higher rates of infection and more severe disease. HIV status may affect the ability to respond to vaccines, and this is an important factor in the clinical trials performed in South Africa. A second consideration is what SARS-CoV-2 vaccine strains are circulating. Were there any variants in the study? If so, which ones? The UK, South African, Brazilian, or now the Indian variant? For example, the overall protection against moderate to severe disease with the same Johnson & Johnson vaccine was 50% efficacy in South Africa, but 72% in the United States. The efficacy of a vaccine may be decreased if the predominant virus strain does not match the vaccine strain. A third consideration is the definition and ascertainment of the endpoints. How are symptoms monitored and collected? Are the endpoints any symptoms, mild to moderate, or severe disease, hospitalizations, or deaths? Also, there may be varying definitions of severity. Next, the timing of the vaccine efficacy assessment is also important. If symptoms are monitored from day one after vaccination, there won't have been time to develop an effective immune response. For example, the Pfizer vaccine had 52% efficacy when counting cases began after the first dose, but the efficacy increased to 93% if the cases were counted only between day 15, the start of an effective immune response, and day 21. Alternatively, if cases are counted over a long period of time, one may have either waning immunity or new variants. Another consideration is the potential for treatment bias. Different use of treatments may affect the number of severe cases and outcome of these cases. In the US, use of steroids, monoclonal antibody, or the antiviral remdesivir may affect mortality assessment in patients. Also, adherence to public health measures like masking may also impact the endpoints. There are other considerations also in comparing the vaccines, such as storage requirements, number of doses required, and side effects. Finally, until there's an established correlative protection, namely a protective level of viral neutralizing antibody, one cannot compare vaccines. While a direct head-to-head study of vaccines is unlikely, there are many ongoing studies which will further define the attributes of each vaccine, and we'll learn more about these vaccines in the months to come. So thank you. What we'd like to do now is to involve the audience, and we have some questions we would like you to answer. These will be yes/no questions. I think we will begin, Kim, with the first yes/no question. Have you had symptomatic COVID? Please indicate. Well, it looks like most of the respondees have very nicely have not had any COVID. If you've had COVID, are you still experiencing any symptoms? And I assume we have a small sample size on that one. Very good. And so the having had very strong responses on the first two questions, on the third question, please, Kim, have you been immunized? Okay, well, that's great. Now, that one person who is not immunized will please address the next question.
Alan, I was a little bit curious whether, because we've had one shot, we live in Toronto, and you may have read that Canada is way, 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 way behind with full vaccination, about 5% of the relevant population.
So does that mean that you've been partially immunized, or?
There wasn't scope in the quiz, I mean, in the to elaborate on what you meant by immunized. So we haven't had the disease and we've had one shot. So I guess we've got, and it was Pfizer. So I guess we've got 85% efficacy.
At least, that's true. Very good.
So the Canada, if there's time, the Canada situation, maybe most of the audience know, but some interesting dynamics of how they have addressed the lack of supply of vaccines.
I think that's an issue that can come up in the discussion. So what we plan to do, I think the last question might not even be relevant, since if you haven't been immunized, why haven't you? So that may be a moot question. So at this point, we do have a classmate who has had COVID and who has a way with words. And so I'll ask Steve Bergman to give his comments. Steve? Are you there?
So as many of you may know, after college, I went to Oxford, and then I wanted to be a writer. And lo and behold, because of the House of God, which is Beth Israel Hospital, that was my first novel. And a lot of people hated it, but thank God all of you, this age, my people, loved it. And it actually, you know, it's a classic now. And so I became a novelist, written a bunch of books, and I got an offer to be a professor of medical humanities at NYU Medical School 7 years ago. And I always wanted to write a sequel to The House of God, but I was out of medicine. I was just writing. And so I joined them. I took that chance. And I all of a sudden had a very clear, I'd been out of medicine, and I got a very clear vision of what the hell medicine is now by the hospitals there. And NYU is a terrific place. I love it. I've been there 7 years. And the things I noticed were money and screens, right? Which is money and money. And so the thing that gets me going to write is injustice. And the House of God was injustice of medical training, which was brutal, as we all know. And And this one is different because I realized it's an unjust system. So the unjust system is about what the new novel is, the sequel called Man's Fourth Best Hospital. And you might be able to figure out which this is based on. I can get myself in a lot more trouble now. My two worlds came together in a very, medicine and writing, because it was in March of 2020, I was doing appearances between big crowds in New York at Montefiore and NYU and downstate Brooklyn, I think, which were hellholes of the COVID just starting. And the only warning was don't shake hands, And so I came back and I had caught the COVID. One of the people who I'd had dinner with that night at Montefiore was dead the next week, so that wasn't very helpful. He was that famous surgeon that separated twins. I don't know, I forget his name, at Montefiore. So I promptly gave it to Janet, my wife, my long-term wife, and she didn't like it too much. And we both got about as sick as we've ever been in our lives. But yeah, it was clearly COVID, and we were in good touch with our doctors, and we could almost feel the COVID tiptoeing up to our lungs and looking over, and saying, no, I don't think so, not this one, And so it was a couple of months really to get back, really a couple of months. I've never been through anything like that, but luckily we didn't have to have hospitalization. And so, I'm very, very glad we're having this panel. You guys and women are great. I'm very proud of all our class. Paul Lankin was my freshman and on roommate. We loved each other. We hated each other sometimes, but we're good friends, and I'm very proud about that. But my concerns have led to, the injustice now is about. I'm writing about Hudson, New York, a little hospital there where I grew up, and it was taken over by one of these private equity, chains. And the first thing they do, of course, in a lot of rural hospitals, as you know, probably, they get rid of obstetrics. So there's a 15,000 population, Hudson, New York, and women have to drive 40 miles to get any attention that way. So that got me going. And this is sort of bringing together the House of God people, and then the doctors from Hudson, which is where I wrote one book set in Hudson. That's quite a different style about going back home. So that's, I'm done.
Oh, great. Well, thank you. How are you feeling, by the way? Any long-term symptoms?
Aside from getting old, every time I can't remember a name, I think I've got the symptoms. But no, we're good. We're
Okay.
good.
Yeah. All right. Well, in the meantime, it looks like we had a number of questions, and a lot of them are directed toward you, Beverly. So I'll just read a few of them, and then I'll let you tackle them. One is from Alice de Barbanel. What do you think of the evolution of abortion with pills technology will be in the next 20 years? Andy Levy. Hello, Andy. Hi, Beverly. Excellent work. Is there telemedicine across state lines? And if so, have states where abortions are restricted challenged such telemedicine? And I think those are two of the urgent questions for you.
Thank you. Yeah, they're good questions, and I kind of have answers, but probably it's worth some discussion. But the long-term view, I think, is that this will take over, pills will take over to be most abortions, and beyond that, in the sense that I have a vision of pharmacy access and people who miss their period by 2 or 3 days, just go pick them up, take them home, and they have their period. And I think that's going to be more and more how people avoid having another child that they don't really plan for. So I do think that there are many, many things that can make this amazingly accessible technology, and a lot of the difficulty in getting things done is purely political. So it's a kind of interesting confluence. Andy, hi, thank you for the question. Yes, this is an interesting aspect of working on this. There are 19 states in which you cannot do telemedicine for abortion for various reasons. Some of them are statutes that say that, and it has nothing to do with pills. Some of it has to do with the fact that there are certain tests that are required, like you have to have an ultrasound with the physician standing there and showing it to you. So you can't do telemedicine in those states. There are other states that explicitly prevent telemedicine for abortion. There in Texas, in fact, you cannot mail pills to patients, any pills, not penicillin, not abortion pills. So there are lots of different problems in at least 19 states. However, we've started to do something slightly different, which is to find borders that are near states that have a lot of restrictions. So, for example, El Paso, Texas is very close to New Mexico. Georgia has very good laws, surprisingly, but all the states around it don't. So people from Tennessee can go to Georgia, and people from Texas can go to New Mexico, and we send the pills to a P.O. box in those states where it's still on the side where you can receive pills, and then people can pick it up from the P.O. box, and they can swallow the pills while they're in the state with the P.O. box, or they can do whatever they want with them. So.
Okay, thank you. Luli, did you have a question? I see you're in the chat box and you're on mute.
No, I had no question. I wanted to say thank you very much to all of you. It's great to see you, Alan. You're the only one that I really knew of this group, but I appreciate all the information.
Well, thank you.
Very.
Also, we have a question from Michael. What might be the timing of moving the currently available vaccines from FDA emergency to permanent approval?
That's a great question. I can't speak for the FDA. Both Moderna and Pfizer have now submitted paperwork. Apparently, there's a huge amount of paperwork associated with full approval. And the FDA will go through the data. They have a lot more data than they had when they did the original emergency use authorization, because now literally hundreds of millions of people have gotten this vaccine. So how long it will take the FDA, I cannot predict.
Okay. And Fred Lowenfels has a question for me. How long do the vaccines last? And the answer is we have no idea. In fact, we aren't even sure of what are the real correlates of immunity. On the one hand, people talk about having antibodies that neutralize the virus, but we also have no idea, or we have some early ideas that the cellular immune system also plays an important role. Those are a little more difficult to evaluate in the laboratory. But I think what we'll find over the next few months is we'll see if there is waning immunity and whether people who have been immunized with the various vaccines, if they either are reinfected or if they're reinfected and actually come down with symptoms. So we still have a lot to learn. So I'm sorry at this point. And also an issue is whether or not we will be needing booster doses. And again, that will perhaps depend on the variants that are circulating and the various target population, the elderly or immunosuppressed, for example. If there aren't any questions from the audience for the time being, I have a question for our panel, and I'm going to ask Paul to take this, and I'm going to ask, do you see any long-term effects of the COVID pandemic on our health system, both the long-term good effects or the bad effects. And after Paul, any of the panelists who want to jump in, please feel free.
Well, I think there are some silver linings to this terrible situation. I think the acceptance of telemedicine and having the government pay for telemedicine visits comparable to in-person visits makes a lot of sense. And there's a lot of Americans in rural areas that are not easily accessible to major hospitals. I think in Pennsylvania, we have 4 counties that have no hospitals. So I think telemedicine could really be a boon to access to healthcare, mental health care and non-mental health care. The other thing is this messenger RNA. I think a parallel group at the University of Pennsylvania spent decades before it was fashionable studying messenger RNA and the potential for its use as a vaccine. And Katie Kiriko and Drew Weissman were the 2 scientists at Penn that pioneered this. The whole process of developing these vaccines that are so effective and relatively very safe, I think is very impressive, a silver lining. And I think as the pandemic, as this coronavirus evolves, the vaccines will evolve. So we're not talking about the same vaccine probably in a year from now. It's probably going to be tweaked. But these visionaries have hope for universal flu vaccine based on this technology and multiple other vaccines coming down the line. So I think this is a major step forward in science and clinical application.
Okay, well, thank you. David Losk would like to ask a question by himself. So David, please take the floor.
Yeah, thank you, Alan. And I'd like to congratulate the whole panel and thank you for enlightening us on your experience with COVID, and especially to my 2 good friends, Dr. Cross and Dr. Olans, and also to Toby. It's nice to see you again from Quincy House. The question is this, Alan. When I was working in public health in the third world, we found that we had a number of issues with mothers of all education levels and all SES statuses accepting or denying childhood vaccines to their infants. And these were the vaccines against the common illnesses that we were all vaccinated against: measles, mumps, chicken pox, whooping cough, all the rest. We found in our work then that by crafting some culturally appropriate messages, we managed to get a sizable percentage of those initial deniers to accept the vaccine for their children. However, our experience showed, and especially in the context of today, that a little knowledge is a dangerous thing. And I'm not so sure, the question is this, I'm not so sure now if by crafting culturally appropriate messages, if something like that exists, we can reach that sizable percentage of people today who insist that the vaccine is evil and that they will not accept it. We have an obvious political variable at play now, which I didn't have in the third world, but we have other things at play as well. So my question to the panel, any of you who want to take it on, what would you recommend in terms of trying to message? Because we get one chance at the message, only one chance, and we have to get it right. So what would that message be to those who are not accepting the vaccine currently?
Dick, do you want to take that on?
Toughest question to me. David, it isn't just in the third world. What is very disappointing is the fact that there's even a sizable percentage of healthcare professionals who are waiting for the appropriate time to take these new vaccines, in spite of the fact that we've heard over and over from several of the panelists that this isn't so new. In fact, it's more developed than a lot of the vaccines that they are used to taking now and had a lot more experience with in terms of its safety and efficacy than did the polio vaccine when it first came out, than did the measles vaccine when it first came out. So I used to have faith in the simple common sense approach that said, there's a choice here. You can choose the risk of the prevention, or you can choose the risk of the disease. And the disease is killing people by the hundreds of thousands and hospitalizing many more. And the side effects of the vaccine are in the simple numbers, a few dozen at most. But that doesn't have any purchase. Lately, I've been listening to books on risk perception and the unfortunate nature of the fact that, apart from the fact that common sense sadly isn't very common, it's the fact that humans tend to look at things that they're dealing with immediately in a different way than things that are off in the future. And having to take the vaccine is something you have to make a decision about today and get a shot. Not such a problem, I would think, but to some it is a lot. As opposed to something that is supposedly going to help you in the future, which is difficult for the human mind to grasp as a true benefit.
If I could just interject something here, Dick, actually what we're seeing now is a real ethical legal issue, and that is that you pointed out that a lot of the healthcare personnel themselves aren't being immunized. And there are nurses in many medical centers who are suing their hospitals for not allowing them into the hospital without a vaccine. And most of us who have been working in hospitals know that every influenza season we're encouraged or sometimes required to have our influenza vaccine. So that this really raises a whole bunch of very difficult issues. And as you point out, it's a lot of the healthcare personnel themselves who are electing not to be immunized.
One last curious thing, though, when we found that problem facing our hospital, facing that with the influenza vaccine, we said, okay, fine. All of you people who have suddenly developed egg allergies don't have to have the vaccine, but we have a responsibility to the patients that we serve as well. And therefore, if you don't get immunized, then you must wear a mask for the entire influenza season as determined by cases. And you must wear it from the minute you step into the hospital until the minute that you leave. And what I discovered was that immunization cures egg allergy.
Toby,
They were inconvenienced enough to have to wear a mask.
Yes.
They were able to take it. That's why I'm supporting what the CDC is doing now, because the impetus to go to a Red Sox game or to be able to fly outside the country or even to take a travel vacation they wanted to take may be a greater impetus towards immunization than saving their lives theoretically.
Toby, you had a comment?
I make two comments. The first is that I think that one of the things driving this, because there are a lot of disparate groups that don't want to be vaccinated, from anxious moms to dyed-in-the-wool anti-vaxxers and all these different elements. But I think that if you want to aim for that middle that are probably coachable or teachable or winnable, I think one issue is fake news. We heard a lot about that during the last presidential campaigns and so on. I don't need to rehash that, but my daughter works at an emergency department in Greater Boston also, not mine, but a different one. It's a large academic medical center. And she said, none of the nurses are getting vaccinated, Dad. And I said, why is that? She said, because there is a rumor going around the internet that it causes infertility in women of childbearing age. So all these 20 and 30-year-old nurses were simply not getting vaccinated. So I think the national effort to begin to think a little bit about, troll farms and fake news, I think may make a dent. But my question really, it's more of a question to Dave's question, and it's really to Paul. I saw in today's Globe, this fascinated me, because I think that you try logic, reason, teaching, all the things we learned in ethics. But in fact, today's Globe cited that some states are experimenting with allowing people who are on the fence about getting vaccinated to join a lottery. If you get vaccinated, you get a lottery ticket and you can win all sorts of money. I'm kind of wondering what that, I wasn't sure how I felt about that ethically, because it seems like kind of a hard sell to me. But on the other hand, if it works, you know, I was just fascinated by that.
But I think, go ahead, Beverly.
Yeah, I would just, as an employer, I'm president of an organization and we have to make this kind of a decision. And I've looked a lot at the labor law situation and other things and finally came to believe that we could, if we wanted to, insist on everybody being vaccinated, but ended up thinking that the best thing is to say, if you don't have a vaccine, you must wear a mask all the time in the office. And that's not going to be very helpful, very good for people. And I think they will all get vaccinated. We only know of one person who won't, so right now, but we're working on it. But I wanted to go back a little bit to the prior question, which is what did we find out about the long-term issues? And I think one of the things we have to remember is we're in a good place now, but we weren't in a good place before January 20th. And I think we have to realize how vulnerable our health systems are to politics and particularly to bad management. And so I'm very concerned that we have systems that are more robust to standing up to bad decision-making in various agencies, et cetera, et cetera. And I think that we ought to spend some time thinking about how to be more robust, no matter who is elected to what. You know?
Following up on Toby's observation about state inducements to vaccines with lotteries, people have commented this, there's a certain moral hazard that here we are trying to offer inducements to our population to be immunized, whereas outside the United States, perhaps even in Canada, there are people who want the vaccine but can't get it. And that has raised at least an issue about what is our obligation in the United States to help the rest of the world in terms of immunizations and vaccines, because sooner or later, variants that are generated outside the United States may find their way here. So I want to ask Michael, if you would perhaps elaborate on a thing we had discussed earlier, namely, there's been a lot in the papers about having big pharma give up their intellectual property so that the rest of the world can have vaccines. And you made an important point, which I don't think has been emphasized, and that is, what is the difference between the NIH, for example, licensing a vaccine versus giving up any intellectual property rights to it?
Yeah, so it's a complicated question, and it has to do with legislation that was passed by Congress many years ago, the Bayh-Dole Act, which was really set up specifically to encourage companies to get engaged in high-risk development of drugs, and this was pretty high risk. Many companies got huge upfront payments from the government to produce doses. It's the big pharma, and in some cases, biotech in combination with big pharma, that can produce hundreds of millions of doses. This is not something a mom and pop operation can do. There's a lot of intellectual property involved. You heard from Paul that there's the use of the RNA, for example, to make vaccines. There's the modification, the genetic modification of the virus, spike protein itself. There's the whole production facilities, which varies a little bit from vaccine to vaccine. And it's just simply saying to, let's say, a country, third world country or country in Africa, you can have the intellectual property, does zero to their being able to produce the vaccine. They don't have the wherewithal to do it. What we really need are ways to license easily at low cost to anybody who wants to produce the vaccine, give them the wherewithal that they need. NIH certainly will do that. That's one of our functions as a government agency. The companies, I think, can be convinced that this is a good thing to do from the point of view of their own PR. So I'm hopeful that that this is not an intellectual property issue. It's just the wherewithal to produce billions of doses of vaccine is not yet there. The production facilities in the countries that need the vaccine.
Actually, to follow up on that, the largest producer of vaccines in the world, the Serum Institute of India, had an agreement with COVAX, which is the agency which would supply vaccines for the rest of the world. They were going to deliver these vaccines to COVAX, who would then distribute it to countries that need it. But because of the huge outbreak now in India, the Indian government has said that the Serum Institute cannot export any of the vaccines for COVAX or anywhere else. They have to be used in India. So the world problem is fairly complicated. But speaking of the world, I have a question here from about travel. And it's a question that says, with the widespread evolving success of the vaccine effort in the US, I assume it's pretty safe now to travel to most parts of the United States. But how about other parts of the world? Where can one find out where you can travel safely regarding the likelihood of not getting COVID? And there's a straightforward answer to that. There's both the CDC and the State Department. On their websites, they will indicate not only is it safe to travel based on COVID, but other safety features as well. So that's one place. Before we run out of time, I would like to ask our audience a question, and has COVID affected your plans for retirement? And if anyone wants to either address that, either in the chat box or volunteer for a 2 or 3 minute summary. Donna, go ahead. You're on mute.
I know, I'm good. Okay, can you hear me?
Yep.
I've had an unusual experience this year. I'm a psychologist in solo private practice. And my plans have been to continue working, but I have some control over it such that I could not take new referrals, or as people left my practice, not fill that slot. And COVID hit, and all of a sudden I was inundated with requests. And I have worked harder this year than I have in the last 5 years. And it came in the form of former patients calling up and saying, I saw you 2 years ago, 6 years ago, you were helpful then, I really need to come back. Those are requests that I really felt I couldn't turn down. And there were a couple of other kinds of requests. I have a subspecialty in infertility, and those requests are very hard to turn down. But I have found myself exhausted, quite tired. One of the slides was self-care in the time of COVID. And how many times have I shoehorned someone in for an extra session, or called, at night when I was really tired and would have preferred to put my feet up. Things I would have done earlier on in my practice, and now I want a less pressured practice so that I can have some more free time. But COVID really changed my life this year. And now that we are freer, although I did put one in chat earlier, and I was wondering if any of you were willing to comment on how safe we should be feeling at this point in time. This past Memorial Day in Massachusetts, Governor Baker said, no more restrictions, you can do whatever you want. Well, I went to a farm stand and I still wore my mask. I'm not ready to do any far-fetched traveling. I'm not willing to, I haven't been in an indoor restaurant since this started. And it's not that I'm certainly about to think about going to an outdoor restaurant in the summer where I can sit on a deck somewhere, but I found myself very hesitant. I have someone in my practice who has breakthrough COVID, thoroughly vaccinated, got it, is now doing a total neurological workup because he's having vertigo as one of the symptoms, which apparently is one of the symptoms of breakthrough. So how do you feel about that?
Well, let me just mention one other thing. I think Emily Hodges has her hand up to respond to the question. Then we'll see if any of our panelists want to respond.
Sure.
Emily? You're on mute.
My question has to do with the number of deniers, people who do not want to have vaccines. And it's, to me, 95% political. I'm sure there's a small percentage of others. And I heard on NPR, the only presentation that seemed to get through to them was when Chris Christie, a prominently known Republican, talked about his hospitalization and how many people in his family had died of COVID. That was the only thing that seemed to change their mind. And to me and the public, when I listen to NPR a lot, but when they're talking about vaccinations, they just don't seem to be addressing the fact that it is a political situation. And what can be done about that?
Well, I think that there's a colleague of Paul, his name is Paul Offit, and he's written extensively, and you've probably seen him also on TV a lot, which he's confronted the vaccine deniers and questioners extensively. And I think if you perhaps either go online or look for one of his books, I'm not being his book promoter, but he really is a very eloquent person who's been doing this for a long time. And it's a complicated issue, complicated all the way back from the time where there was I won't even say misinformation. It was the lie by Dr. Wakefield in England about the autism and vaccines, and it all took off from there. And even though he was disbarred from medicine in England, he found a welcome in, of all places, Texas, where he's a hero. So I think if you read Paul's books or any of his comments on website, I think you'll find at least explanations, if not answers.
Thank you. His last name again?
How do I put up a hand?
I'm sorry?
How do I put a hand up?
It's at the bottom of the screen there. And
Reactions.
Onto the screen where I don't see it. Well, can you consider my hand up, Harriet Katz?
I will, and since we're nearing the end, it has to be under 3 minutes, if that's.
I'll be happy to be quick. I can answer the retirement question and the safety question.
Great. Thank you. Welcome.
Am I on?
You're on.
Okay. I'm a cellist and a composer, and there's obviously were no performances, but I found I was able to be a prolific, very prolific composer because of all sorts of virtual situations, including synthesized sound. As for safety, I'm very much like Donna. I live in a suburb of Baltimore, and I do not feel safe without a mask. I don't care what they tell me. Trader Joe's says I don't need to wear a mask. I wear a mask whenever I go out and when I go anywhere in my condo building.
Okay, any other comments? We're nearing the end of our hour and a half, and I'd like to ask our panel whether they have any parting words before I give a wrap up. Paul, Michael, Beverly.
Yeah, I'd like to thank Donna for being available for her clients as a psychologist in time of need. I mean, I think those are the heroes, the unsung heroes, and there is a sacrifice, and I think you can feel satisfied you did your duty, and hopefully get some time to put your feet up later on.
Thank you, Paul.
Toby, with the decrease in infections and a impressively falling death rate. Have you seen any change in the emergency room over the last month as we've gotten our immunization rates up?
Yes, I think that people, a pundit a year ago said COVID fear is being replaced by COVID fatigue. And I think COVID fatigue just for general population and for providers is a real thing. And people were getting a little loosey-goosey even 2 or 3 months ago. But now with Governor Baker's pronouncements, it's people are beginning to, at the hospital, you have to wear a mask. You just do. You can't get in without it. But beyond there, people are taking their masks off more, sipping iced tea. We're not putting on PPEs for every known COVID patient the way we did prior to vaccinations, and it's gotten much looser. If that's good or bad, I don't know. I still do most of the things because my wife's very frightened, but there's been, I think, a sea change in the way that we address the environment. I think that's true. The major driver now are the hospital rules, not the individual provider's decision making.
And Dick, in 2 minutes, any changes from what you see in private practice?
Yes, in our hospital, the age of the patients being admitted for more severe COVID has dropped spectacularly from the early surges. We're now admitting patients between the ages of 20 and 50 who have COVID. I don't think it's just because the nursing homes have had a loss and have immunized their clientele. I do think that the virus is taking advantage of the population that's available to it. That's nature.
Well, very good. We are at the end of our time, and there are a number of questions in the chat box, which unfortunately we won't have time to address, but you have our email addresses of the panelists in the Red Book. So please address any questions to the panelist of choice, and I'm sure all of us will be happy to get back to you. So by way of wrap up, the COVID-19 pandemic has been really a defining event in our lives, both at the personal and societal levels. It's forced us to consider what's most important in our own lives. It has affected our relationships with our family and friends, and it has revealed deficiencies in our public health infrastructure, medical care system, and government policy. In the ensuing years, we'll learn more about the virus, our vaccines, including the durability of the immune response and the need for additional immunizations. We'll also learn how this pandemic has changed our society and if any lasting changes for the good emerge. These are topics for our 60th reunion, God willing. Thank you for joining us.